Right. Well, this is a talk about preventing diabetes, so I thought to keep it interesting, why don't we do some real medicine right here? Let's check somebody's blood sugar before we even get started. And who are we going to check? Well, I'm the doctor, but I'm not up here looking down. I'm your equal, so let's check my sugar and get started. And then later on, we'll ask for volunteers for who wants to get their glucose checked. I remember back in the days when we started talking about cholesterol, everybody's supposed to know their number, and then blood pressure is the same way. So now blood sugar is coming into the same kind of light. So we may as well get it out of the dark corners of needle stickings and everybody realize that this is no big deal. So you got the, you're all ready for it? Is it all ready to go? Okay. So we tend to warm our fingers up and pick a finger that looks like it would be the one to use. Okay, I'm getting a little drop of blood there. I did not feel a thing, by the way. Okay, and it doesn't take more than just a couple seconds. My blood sugar is 86. Okay, so that's a good place to start, especially when we get further down the talk. I'll talk to you about my own personal experience with this condition. I do have type 2 diabetes, and I've got it into remission through a combination of weight loss and exercise and stress management, and I'm not on no medication. So I'll share with you how I got to that point and how you too can experience good health through a minimum of pharmaceuticals. So here we go. The problem with the epidemic that we're facing of diabetes in America today is partly lifestyle. It's mostly lifestyle. We have this obesity epidemic overwhelming us, where we go from 1985 here with a pretty lean country with not much of the population over about 14% of obese parameters. But you go to 1990 and it turns into a different pattern altogether. 1995, we're up to half the country is up to 19% overweight. Then we go to 2000 and we're over 20% for the Midwest and the South. Then we go to 2005, and here we're in a new category. We had to change colors. We're up to over 30% of the population, at least a BMI of 30, which is not really that heavy. Colorado lags behind here. Here's 2007, and we keep going, and finally Colorado joins the rest of the Southwest with at least a 24% obesity rate. So this is part of the problem is the extra fat tissue we're carrying around, and another part of it is our lifestyle of sedentary activity where we're just not moving enough. And I'm as much as fault as anybody. I sit in front of the computer screen, I sit in the exam room, I sit at my computer at home, I sit in my car driving to work. So all of those things lead us to this problem. So how big a problem is it? It's really, really big. We've got almost 26 million people in America with diabetes, and 7 million of those don't even know they have it. Then there's almost 80 million pre-diabetics, and 90% of those don't know that they have it. So I like this analogy to an iceberg here, where you see diabetes or pre-diabetes as the visible part of the iceberg, and then that's below the surface is lurking. Now it's also worthwhile, I think, to look at the iceberg as the continuum of the underlying condition that is the cause of the diabetes and pre-diabetes. It's called insulin resistance. And people will say to me, "Doctor, last time you told me I was diabetic and now I'm pre-diabetic. Well, how does this work?" Well, it's all part of the same process. If you look at the iceberg as insulin resistance, And the tip of the iceberg is diabetes, and the subsurface area as prediabetes. You can see that they're all a continuum, all part of the same process. So, well, how do we define diabetes? Now, back in the early 80s when I started practice, we looked at blood sugars and said, okay, anything under 140 is normal. And that changed fairly quickly to anything under 126 was normal. And so if you had a blood sugar, if you now have a blood sugar fasting greater than 125, you're defined as diabetic. Now, there are a lot of other factors that might go into a blood sugar of that level, so there's a gray zone, and things are always more complicated than they seem. Now, for prediabetes, you have the blood sugar from 100 to 125. That's called prediabetes, fasting. And then a blood sugar fasting of 86 to 99 is considered normal, but it's not really that normal. We consider ideal to be less than 85. So we'll talk about why we got to this point. And also about all of the different governmental and non-governmental agencies that are involved in putting their committees together to deciding what they're going to call diabetes or not diabetes or prediabetes or insulin resistance. So you can see that the more people involved, the more opinions you're going to have as to what constitutes a definition for something. So if we look at these fasting blood sugars, if you have a blood sugar fasting less than 85 and call that a reference point, and then look at people who are in the high normal range, 95 to 99, this cohort here has greater than 2 times the risk of developing diabetes over this group of people that are less than 85. So you can see something's going on here as we get above 85. There's definitely some process that is not right. Otherwise, there wouldn't be this increased risk. So we also see that your risk of dementia goes up as your blood sugar fasting goes up from the low normal to the high normal. So we're starting to think, well, normal isn't really normal anymore. So we're in a process of adjusting our normal blood sugars lower. And as far as I'm concerned, it's just like blood pressure. The lower you can go and not pass out when you stand up, the better off your heart's going to be, with certain exceptions. Okay. So people ask me, doctor, what's a good blood pressure? So, well, if you're not dizzy when you stand up and it's 100 over 60, fine. That lowers your risk. There's no sharp cutoff in the graph. When they did the original testing on blood sugar in the Framingham Heart Study, where Framingham, Massachusetts, the entire community is part of an ongoing longitudinal study, they found that people with lower blood pressures, as long as they felt fine and they didn't have any other reason for a low blood pressure, they had the least risk for heart disease, stroke, and kidney failure. And we're starting to see that also in the blood sugar realm. So we hear a lot about hemoglobin A1C. People will say, doctor, why can't I just get my hemoglobin A1C checked? And that'll tell me whether my sugar is good or not. And my relative has diabetes and they get their blood sugar, their hemoglobin A1C checked, and their doctor says, don't even worry about your blood sugar, just get your hemoglobin A1C. And it is a quick and easy test because it involves just an additional blood sample, but is it really very accurate? It is okay for monitoring you once you have diabetes and you're on medication. In fact, the standard for targeting your hemoglobin A1C is 7. And people come and say, doctor, I heard 7 was okay. Anything below 7 or 7 or below is a good hemoglobin A1C. But there's confusion there because hemoglobin A1C is really best for monitoring people who are on powerful medications that have a risk of low blood sugar. The side effect of your diabetic treatment, once you're getting into insulin shots or strong medication, is your blood sugar can go too low. And that's why they picked, through a process of committees and looking at the statistics, that if your hemoglobin A1C is 7 or below, then you're okay for lowering your risk of low blood sugar, which can be very serious. And our whole plan here is to try to keep people from getting to where they need powerful medication or insulin shots so that they're not at risk of hypoglycemia. So if you look at hemoglobin A1C and the different numbers involved, you can see that if you're using a target of 7, a 154 on the average is up there. It's definitely not in the desirable range as we were talking about. And 5 itself is fair, but it's nothing like 85 that we were talking about. So let's take an example. Here's an example of one patient, and we'll call him patient number 1, had a hemoglobin A1C of 5.6, which is considered that's the standard desirable range. And we did what's called a glucose tolerance test. I know most of you have done those by now here at least once. And we have you come in fasting, do a fasting sugar. This person had one just below 100. And then we give you 75 grams of glucose liquid. You drink that, and we check your sugar again in an hour and again at 2 hours. And if there's any question where it's going, we may check it even further. So this individual had a blood sugar that went up to 250 something. So that's definitely in the diabetic range, where we have a cutoff for this test of 200 as being the limit for diabetic and 140 as being pre-diabetes. So despite having a normal hemoglobin A1C, this person had a diagnosis of diabetes. Over a period of a matter of months, through cutting out carbohydrates and limiting other calories and losing a little weight, we repeated the test, and it shows that this individual is pre-diabetic, but definitely has a much healthier looking curve on the chart than previously. Despite, yes, sir?
According to the dates, are they wrong? Because you're saying the yellow was after the blue.
They are.
In that date.
Oh, I didn't notice that. Okay.
Yeah,
they're reversed. Olivia's tricking me again. Okay, so here's an individual who has a blood sugar on this was the first one, and he came back with a second one going up to 300. Obviously, they hadn't really been able to get into the lifestyle treatment as much as possible from the number of problems related to hospitalizations, family tragedies, that sort of thing. And despite at this very same time, the very same blood draw, she had a blood sugar or a hemoglobin A1C of 6.3, which is definitely in the diabetic range of 300. So you can see that we can't guarantee results here. Life goes on, and each of us is an individual, and we have to look at your individual problems and challenges in trying to determine a treatment plan that works best for you. This individual may end up on medication for diabetes sooner rather than later if we don't get this trend under control. So, is the hemoglobin A1C a good screening test? I would say no. I don't know. Maybe we should take a vote. But my opinion is no. So how do we diagnose diabetes? The gold standard is the glucose tolerance test, which I described, and which has the cutoff of 200 for being diabetic and 140 for being pre-diabetic, and anything under 140 is normal. In contrast to the fasting blood sugar, where technically anything under 100 is normal, but 85 would be ideal, and diabetic is over 125. The hemoglobin A1C is used a lot in standard medical care where doctors don't have the time to have you in the office for 2 hours for a test. And this is used extensively as a screening test, but it's not near as accurate as the glucose tolerance test. So what are we worried about with diabetes? Why are we treating it in the first place? And why can't we just let our sugars go to 200? What's the problem here? Well, there are a lot of problems that take place, and it affects every cell in your body. As you know, glucose is the fuel for your body. Every cell, every tissue, every organ in your body needs glucose to function properly. It's your body's fuel. And insulin is the key that allows the glucose to flow into the tissues where it's needed. And if it can't do that, it builds up where it doesn't belong and causes inflammation and disease, including in your eyes, where you can have cataracts, you can have retinal problems, even cause blindness, the heart and the brain, where you have vascular problems with hardening of your arteries, cholesterol deposits can form, your nervous system can be affected, causing neuropathy, including numbness, tingling, pain in your feet, carpal tunnel syndrome, GERD, reflux disease. All of these things are related to the effect of high blood glucose on your nervous system. And time and again, we see people amazed that their GERD goes away, that the tingling in their feet goes away, just from getting their blood sugar from high normal or insulin resistant levels, but non-diabetic levels, getting them down into an ideal range. Likewise, diabetes can cause poor circulation in your feet, leading to amputations, infections. It's the leading cause of kidney failure, gum disease, periodontal disease can be affected by diabetes, and people with diabetes and pre-diabetes are more likely to be diagnosed with dementia, and that includes people who have a high normal blood glucose. So that's enough to get your attention. It sure got my attention. So what are we going to do with this process? I like the analogy of a river, of a mountain stream that flows down through the mountains and then out to the prairies and finally to the ocean. And during that process, other tributaries are contributing to its flow. There is silt from farmland. There are industrial wastes accumulating in the river. And I like to make the analogy that this is like waiting for the diabetes to be diagnosed. If you want to wait until your river's already polluted, then you're going to have a much more difficult time trying to clean it up. It's going to be a Superfund site. In other words, you're going to have all kinds of resources dedicated to trying to clean up your metabolism. And if we could keep it healthy and pristine with ideal blood sugar, ideal cholesterol, ideal blood pressure, all of the different factors in your blood being just like a clear mountain brook, then we're miles ahead in the process. So insulin resistance, which I already alluded to, is this process of as glucose increases in your bloodstream, it affects the ability of insulin to bind with insulin receptors, the purpose of which is to allow glucose to enter the cell. So it's somewhat of a paradox. The higher the blood sugar, the harder it is for the glucose to get into the cell. And so in a sense, your insulin is trying to protect you, but it all goes haywire. So I'll go through. This is the busiest slide I have right here, and this is from a medical text, but I'm going to explain it in language that we can all understand and benefit from. So this is a muscle cell. Why do we pick a muscle cell here? Because the muscle is the major part of your body that uses glucose. I said that all of your organs and tissues use glucose, but you have, 50 to 100 pounds of muscle in your body. That's where most of the glucose and insulin is going to do its job. So it's really important to look at how muscle works in your body with this process. So under normal situations, you have the fat cells here. Fat cells are important. You have to have a certain amount of fat in your body. You eat something, the fatty acids that are involved with the excess calories that you've consumed are processed and stored in the fat cells as triglycerides. And we can do a simple blood test that tells you what your triglyceride level is. Now, when you then exercise, you release the triglyceride and your body can then use the fatty acids in the muscles, and insulin is activated and allows glucose to enter the muscle cell. Now, if you have too much intake versus the amount of energy that you're burning, your fat cells increase in size. This can be overwhelmed then to a point where your fat cells are overloaded with triglyceride input, and then certain chemicals in your fat cells start acting like an organ, like your own endocrine organ, putting out these inflammatory markers and bringing in white blood cells. The macrophage, that's called the white blood cell. And these white blood cells, the macrophages, then start creating chemicals called, for example, TNF-alpha, which is an inflammatory marker. And this inflammation then affects the ability of the fat cell to put out the fatty acids as needed, and it overloads your bloodstream with triglycerides, and you'll see your blood filling up with triglycerides. Those triglycerides then need to go somewhere. They find their way into the muscle cells, so they give you a diseased muscle where there are fatty deposits in your muscles and in your liver and in your pancreas. And of course, if your pancreas is where your insulin is coming from, that's crucial. So the whole system is deranged at that point, and it's a difficult it can be a difficult cycle to break. So if you're going to wait until it's that far deranged, then you're much more likely to end up having diabetes that's going to be difficult to treat. So the point of this slide is catch this early, prevent diabetes, treat it early, reverse it if possible. Now, this is a typical ad we see in the medical journals. There are a lot of pharmaceutical ads for insulin, for diabetic pills. And I put this up here because we're talking about insulin resistant situation, and I'm resistant to giving myself shots of insulin. I don't ever want to have to do that. I know people who do, and they adjust to it well, but I think this is a good pun in terms of insulin resistance. I think we should all be insulin resistant in this sense. We're going to resist the need for insulin shots. That's my little pun there. So what about people who come to me and say, "Doctor, what's the problem with glucose?" We always saw sugar, and they used to advertise sugar as an energy food. The Kool-Aid was on TV Saturday morning. Drink Kool-Aid, it gives you energy. Give your children Kool-Aid, which of course is just pure sugar. So what's the problem with sugar? Well, just like any other fuel, and in this case wood, cellulose or wood is a carbohydrate, that burns, and we burn the glucose in the same way that you burn wood in your campfire. It's just under a very well-controlled metabolism. That's why we're not at room temperature right now. Our 98.6 is derived from the fire within us, from burning the glucose from the food that we've eaten recently. So what happens if it gets out of hand? If you put too much wood on the fire, then you have a forest fire. And this correlates or is analogous to inflammation in your system. Inflammatory markers are showing up. You don't feel well, you're sick, you've got the complications of the GERD, the neuropathy, the development of achy muscles, fatigue, swings in your blood sugar where your blood sugar may be going too high because your insulin metabolism is deranged to the point where it shoots too high, and then your blood sugar drops, the insulin stays up for a while, your sugar drops too far, and then you're weak and shaky and don't know what's wrong except that you got to have a candy bar right away. So these are all symptoms of the process. So one other concern we have is with the metabolic syndrome, and this is definitely a disease designed by a committee. Okay, there are about 5 different criteria here. There are 5 criteria, but there are about 5 different standards from these different associations, like the American Diabetes Association or the International Federation for Diabetes and the National Institute of Health. All of these have a different notion as to what these should be. But when you come in once a year to get your comprehensive evaluation here, we do measure your waist circumference. And this is why. Because it's one element in the metabolic syndrome. And the reason I'm talking about the metabolic syndrome is it kind of pulls the whole blood sugar, diabetes, insulin resistant thing together. You can see that this individual has excess fat on his frame, and men too tend to be more apple-shaped as they gain weight, and this is a higher risk than carrying your weight, say, on your hips or on your legs, because it's visceral fat, and visceral fat is more likely to be the fat that is going to be involved with this deranged metabolism with the inflammatory markers I was telling you about. So we've got the waist size, we've got triglycerides 150 or higher, we've got a HDL cholesterol that's on the low side, so this relates to exercise. The best way to raise your HDL cholesterol is exercise. And so here's a marker of exercise from your blood. Other factors go into that too, of course, like genetics. Blood pressure also. It's amazing how close insulin resistance ties to blood pressure. So those inflammatory markers raise your blood pressure. So for years we've been giving people medication for blood pressure and say, yeah, and by the way, your blood sugar's up a little, so you should watch out for that, but here's something for your blood pressure. When really what we needed to be doing is say, hey, let's get this blood sugar down, and then you might not need a medication for blood pressure. So the two are closely related. And then the blood sugar here is 110 or higher, and of course this is being adjusted downward. So if you have any 3 out of those 5, you're diagnosed with metabolic syndrome. And what's the value of being diagnosed with that? Well, for one thing, it cannot qualify you to get your Medicare or insurance to pay for a home glucose monitor. But it also involves stratification of risk. So if you have 0 of those factors from the metabolic syndrome, and we'll call that a risk of 1 over 5 years, your risk of developing type 2 diabetes goes up to 24 times the normal risk if you have 4 or 5 of those factors. So we've got to pay attention to those. 24 times the risk is huge. And then your risk of heart attack also goes up by 3.5 times over 5 years if you have 4 or 5 of those risk factors. So you can see that heart disease, stroke, all these other complications are related. Now, the drug companies would like us to prescribe medication. Of course, they're in the business of having us prescribe medication for you and you taking it and keeping the industry thriving. So they've done tests that show that metformin, which is a common medication for diabetes, which helps your body use the insulin better, the insulin that you do have. If you take people who are at risk for diabetes, but they're pre-diabetic, and give them metformin, over 4 years you can drop their risk of developing diabetes by 30%. And the other arm of the study, besides the placebo, which obviously didn't do anything, you got a 40% increase in diabetic risk from not doing anything, but lifestyle, which is what we're all about here with having a full-time health coach like Olivia on our staff and trying to find ways to improve your life without chemistry, then we can lower, in this study, the diabetes prevention program study showed that lifestyle dropped your risk by 58%, about twice as well as the metformin did. So let's hear it for lifestyle. It was twice as good as pharmaceuticals. So here's patient number 3. We just saw this individual last week. And this, do we have it right here? Yeah, we do have it right there. So it's here he is. Back when we were just getting started with the N1 program and doing personalized medicine, this fellow who we'd been seeing for a number of years and was on medication for blood pressure and had various symptoms. He came in for a screening glucose tolerance test, not really feeling like he needed it. But as you can see, he needed it. His blood sugar went over 200, So I gave him our handout on diabetes and said, look, you've got to get a handle on this before you develop complications. So here he was, a few months later, he'd lost significant weight, had gotten out of the diabetic range and into the pre-diabetic range, and was feeling a lot better with a program of good exercise and nutrition. Here's what happened with his lab work. We send lab off to the Singulex lab, but any other lab could do some of these. We have a hard time finding TNF alpha. And if you remember the slide with the muscle cells, the TNF alpha was the inflammatory marker which was coming out of the fat cells under the influence of those white blood cells that were infiltrating into the fat cells during this dysregulation period. And you can see that his TNF alpha was dropped by about 50% with his program. His CRP, which is another inflammatory marker, also dropped dramatically. His LDL dropped a little. His HDL, the good cholesterol, went up as he was exercising more. And look at his triglycerides. Now we saw that triglycerides were a key factor in this whole dysregulation problem, where the fat starts putting out triglycerides and they're getting deposited in the pancreas, in the liver, in the muscles. He dropped his more significantly than anything else on this panel. It went from about 130 something down to 70 something. And he dropped his small dense LDL, the worst part of LDL. Interestingly, we don't see this very often, but he had elevated liver enzymes, and that most likely was due to fat deposits in his liver. He brought that down to normal with just a few months of therapy. So I'm going to turn it over to Olivia now, and she'll explain how we did that for that individual and talk about some of the other treatments we have here for this problem. So take it away, Olivia.
So, same patient number 3. So the first time he came in, you saw me, we did the first in-body, and almost everybody in here has done the in-body, I'm pretty sure. And this is around the same time he did his first glucose tolerance test. So we see his weight, this is the initial one, the yellow one. And we see his skeletal muscle mass and his body fat mass, his BMI, and his body fat percentage. He came in one other time in between his second glucose tolerance test. You can see he lost a significant amount of weight. His skeletal muscle mass was about the same, but his significant weight loss was in body fat mass. And then when he came back in to do his glucose tolerance test, he lost a little bit more weight. I think it was about 40 pounds total. Lost a little bit of skeletal muscle mass, which is normal when losing weight, and lost more significant body fat mass. And we wouldn't know this. All we would see, if we didn't have the in-body, we wouldn't know how much body fat mass he actually lost unless we wouldn't know. We wouldn't see his muscle mass, and we would not see his body fat mass. So this is why that awesome in-body, it doesn't lie. Okay? And also you can see here, he's had a little bit of, over the last year, he's had a little bit of family stress and other things. So he's a little bit gaining weight, but that's why we're here and we're helping him, keeping him motivated to help reduce more body fat and get that body fat percentage within that healthy range. All right, and why is this such a big problem? Why is this such a big epidemic? A lot of it is because we have sugar everywhere. So why is sugar such a problem? Well, it's empty calories. We consume it, sometimes without even knowing it, and there's no nutrition, it's added calories. Our sugar-sweetened beverages promote obesity, diabetes, and heart disease. It's not just our sodas that we should stay away from. It's also hidden in those healthy vitamin water drinks and those so-called healthy other sport drinks, Gatorade and other things that they promote as healthy when they're really not. They're mostly all sugar. Fructose, it raises those triglycerides. So just like we saw in patient number 3, his triglycerides dropped dramatically while he stopped eating a lot of sugar. Fructose may also boost your visceral fat. Minimizing added sugars keeps a lid on your blood pressure. And most sugary foods are junk. Junk, junk, junk. So anything that is packaged is mostly probably sugar, okay? So even those things so-called healthy, I quoted healthy, has a lot of sugar. We know that yogurt's good for us, but yogurt can also have a lot of added sugar. So that's why finding the no sugar added or the not even the sweetened sugar and add maybe your fruit instead of getting a flavored sugar or flavored yogurt, because that's the same amount of sugar as 2.5 donuts. Sometimes those cashew, they come as healthy too. Those go lean, it sounds healthy, but it's not. It has a ton of sugar in it as well. Protein bars, Cliff bars, Power bars, those are all just high protein candy bars, I like to call them. Also our breads have added sugar. If a slice of bread has 5 grams of sugar and you're having a sandwich, so you have 2 slices of bread, you're eating 10 grams of sugar just in that meal without even knowing it. We come to think that granola bars are good for us. Maybe that Chewy bar only has 90 calories, but it's 90 calories of sugar. Another one that comes off is the Cheerios. We come out with these protein Cheerios that just recently came out. Well, it has 11 grams of sugar compared to 3 or 4, I think regular Cheerios has. But it's got 17 grams of sugar compared to 1 in the original, just to make it taste good. Also our ketchups, our sauces, marinara, teriyaki sauce, all that type of stuff that we love, pickles, everything's got added sugar. So make sure you're looking at your labels and reading the labels to see how much sugar is in one serving. I would like to say less than 5. With breads, 1, maybe less than 1. All right, so with all this sugar talk, we have sweeteners. So one we're going to go over is saccharin, which can actually be more harmful than good. So there's a sweet confusion here. In recent studies of studying rats, they found that it actually increases blood sugar levels by changing the gut bacteria. So a couple months ago, we talked about probiotics and how important our gut is. Well, it can also affect our blood sugar levels as well. So you're better off drinking just water than anything diet, no diet stuff, because that's what it's added in. So what does your plate look like? Does anyone know how many servings of fruit and vegetables we should have a day? Anybody guess?
3.
3?
7.
7? 20. I like that. It's actually 11. So does anybody know about breads and or grains? Whole grains, I should say, not just breads, but whole grains.
7. 2.
4. So we've learned from this pyramid, this food pyramid, but it's actually wrong. It's not very healthy for us at all, and it's actually causing those diabetes and obesity risks to go up. So make sure you have a full plate of veggies. Half of your plate of veggies. To me, I think all that stuff looks delicious. I don't know about you. So body composition versus fat versus muscle. So going back to that in body. Why is this so important? Well, you can see how much more volume this 5 pounds of fat is compared to this muscle. Okay, and so this is I like this visual here. So 5 pounds of fat takes up about a space of 3 grapefruits. Now 5 pounds of muscle takes up about a space of 3 tangerines. And to me, that's a big difference. So what are we going to change from that fat and gain muscle to help us regulate those blood sugars? Exercise, my favorite. So inactivity is a major factor in type 2 diabetes. Why is that? Because we're not using our muscles, we're not using our bodies. Our muscles aren't intaking that glucose to be used, just sitting there and causing more problems than good. So it's critical in preventing type 2 diabetes. So why exercise? It enhances the ability of your muscle to take up and store glucose, which is what we want in the muscle. It increases the transporters that help take up the glucose and become more receptive, which decreases our insulin in the blood. And this equals less sugar in the blood. It increases the muscle mass along with higher metabolic rate. So even while you're resting, you're still utilizing that blood glucose. So here's one of the transporters, which is very important, and the AMPK. And this is just a protein kinase that is utilized and activated during exercise. And metformin is the drug that they give you when you have type 2 diabetes to help regulate your blood sugars. But this is the natural type of protein or enzyme that helps you regulate your blood sugar. So it helps cut off that insulin. So insulin's not just flowing around in your blood anymore, and naturally helps your skeletal muscle and also your fat take up the fatty acids and also that glucose, which is making it more efficient. So steps to help you attain your health goal. So fight your prevention of diabetes. So make a commitment, whatever it is. So I'm going to share mine today because I'm talking about making it public. So for January, my goal is to run a half marathon. So I have it. I'm already started training, which I hate already. But so I put it where I could see it every day. I have my phone. It reminds me to go run in the morning when it's freezing. Create a plan. So maybe this is for you, is to create a meal plan. Maybe it's exercise. So schedule it. It's got to be just as much as brushing your teeth every day. Something that you can just go maybe 10 minutes at breakfast, maybe 10 minutes at lunch, maybe 10 minutes after dinner. Your 30 minutes, that's essential. If you're going to meal plan, go make a shopping list when you go to the store. Figure out what you need, what meals you're going to make. This will help you with not overeating when you come home. You already have a plan set. You're not just going, what am I going to eat tonight? I fall into that all the time. So if you have a meal plan, you tend to have it and you don't overeat. Track your progress. So some of us, maybe it's blood pressure, maybe it's weight, maybe it's blood sugar. Track it. Make sure you're seeing it so then you can see the changes, which can help you motivate you more. Maybe that's also a food diary, writing down what you are eating. Sometimes we don't really think about what we had yesterday, but when we have it written down, we can't lie to ourselves. And also measure your food. See what the measurement and the serving looks like. Sometimes our brains kind of think, oh, well, that's a serving, but really it's 2 servings. And also an exercise diary. See where you're making your gains. If you walk 10 minutes and you're feeling better, add 5 more minutes, and then you can see how much you've gained over a progress of time. Making it public. So tell at least 3 people of your commitment. So you can tell me, Dr. Morris, and then somebody else. And there's your commitment. Voicing and saying it out loud helps attain that goal, helps you kind of rethink and say, oh, I already told this person, so now I got to go do it and put it into action. Another thing, make your kitchen healthy. Discard those diabetes and unfavorable foods. You can mark them as red if somebody in your family cannot live without them, or just toss them out. Get rid of them. Don't even let the habit be there so you're not influenced by them. Stock up on vegetables, fruits, nuts, and beans. Things that if you come home and you're starving, don't go for those chips. Toss out those chips. Maybe cut up those apples or some vegetables and have some hummus and vegetables when you get home, and then you don't have those chips or popcorn to grab. And then also, the most important, create your exercise schedule. It's your number one daily prescription. You're not going to miss your other medications, so why skip your exercise? At least 30 minutes a day, no excuses. I know it's cold out, bundle up. Go at noontime, it's still gorgeous out. I can't go at that time. So ultimately, the choice is yours. We're here to support you, and we're here to help you attain your goal, but you gotta do it. Gotta make that step. And that apple looks so much better than that cookie. And you're never too old. So I have this great video just to end on. This is an 86-year-old gymnast on parallel ballers. She's doing what I can't do.